Hello students, today I will be discussing about the mucocutaneous lesions. The most common mucocutaneous lesion is lichen planus. As I just mentioned, it's the most common mucocutaneous lesion. The etiology is thought to be an inflammatory disease. Now emerging evidences suggest that it is a autoimmune disorder. This tends to affect the oral mucosa as well as the skin. That's why it's called as a mucocutaneous lesion. Though we don't know the exact etiology, it is thought to be related to T cell mediated autoimmunity process. Okay, because of the high aggregation of lymphocytes, it was initially thought to be a chronic inflammatory condition. The possible etiology for unmasking of antigen is thought to be contact allergens, which are present in the form of, which can be introduced in the form of restorations, toothpaste, which bring about unmasking of the antigen, which is recognized by the T cells in the body. There can be similar response that can be seen to drugs and medicines and chemicals and cosmetics, and this have been termed as lichenoid drug reaction. Lichenoid means lichen planus like, not exactly, but lichen planus like condition. So as I just mentioned, etiology, it is basically a T cell mediated autoimmune response where the cytotoxic T cells, talk about autoimmunity, there has to be an antigen and there has to be an antibody. The antigen in this particular case of lichen planus happens to be the basal keratinocytes. Not just keratinocytes, the basal keratinocytes. And as a response to this antigen, the antibodies that are present are the T cells. What T cells? Cytotoxic T cells. So when we have an antigen and an antibody, the response that ensues is T cell mediated immune response. Okay, so how is it different from the antibody mediated immune response? In our antibody mediated immune response, plasma cells produce antibodies which are going to bind with that of the, they usually bind with that of the antigens present. Opsonization occurs and there is direct engulfment and destruction of the antigens. Whereas in a T cell mediated immunity, the antibody identifies the antigen, attaches to it, usually antigen presenting cell identifies the antigen for the antibody, that is the T cells, and when this antigen presenting cell presents this antigenic material, lot of lymphocytes, cytotoxic T lymphocytes, that is the CD8 cells, are recruited into that area, and they will attach onto the surface of the antigen, drill holes onto them, produce cytotoxic substances so that that can kill the cells. This is how they execute the cytotoxic process in the cells. So they force the cell to die by apoptosis. There is no direct killing. They force the cell to undergo apoptosis. So here again, following the same phenomena, antigen, I told you it is the basal keratinocyte. So each cells, almost all cells in the body usually present with MHC1 uh, on their cell surfaces to identify it as self. So once there is unmasking of the antigen that takes place, as I told you, they are recognized as antigen, and the antigen presenting cells, such as the Langerhans cells, pick up this signal and take it to the nearest lymph node to convey the message. So once it is received, the lymph nodes will produce a lot of lymphocytes and send them into that area so that they can be tackled. Okay, so CD8 cells will identify MHC1 on the epithelial cells as antigenic with the help of antigen presenting cells. That happens to be Langerhans cells in this particular condition. Thereby, ultimately, what happens there is the antigenic cells will be forced to undergo apoptosis. In simple, that's a huge process, like I told you. Drug and dental restorative material, mechanical trauma such as Copner's phenomena, viral infections, and unidentified antigens usually unmask the antigen. Lichen planus usually affects primarily middle-aged adults and usually thought to be more common in the female population. Initially, it was thought that it was exclusive for females, but now we have emerging evidences which suggest that a lot of men also tend to be affected with this particular condition. And one more concept about this women predominance of lichen planus was thought to be that one of the etiology for lichen planus is thought to be mental stress. Then the psychological phenomena. Hence, it was thought to be more in females, which is now proven to be a bias. And a lot of males also are thought to present with lichen planus. The classic clinical features of lichen planus is described by the 6 P's as I've mentioned over here. Pruritic, itch, polygonal, the size. There is no fixed size and shape. They are just polygonal with multiple ends and multiple heads. Planar, flat, purple, violaceous patches we say, which can be very well appreciated on a fair skin. Papules, sometimes though they are flat, sometimes you can have papules and plaques or thickening of these surfaces. So 6 P's represent the clinical spectrum of lichen planus, and this is mostly applicable for the cutaneous lichen planus. You may not be able to appreciate all this in a oral mucosal area. Characteristic feature: bilateral white striations, papules or plaques present on the most common site happens to be buccal mucosa there, tongue, gingiva, buccal mucosa, and back into the oral cavity till the esophagus. So any area in the oral cavity can be affected with this bilateral white striations. The classic presentation, the reticular pattern of presentation. So these reticulae or the striations, stria means lines. There is intersection of these lines. So are seen as lacy white patches. Okay, usually they do not carry any area of discomfort until and unless it may be present in an area such as tongue, where the patient may complain of burning sensation in the tongue or loss of taste sensation in the tongue. The inflamed lesion, an open source of oral lichen planus, can also be the reason of burning sensation, which we can appreciate on the skin or in the oral mucosa. Burning sensation along with pain. When we have the clinical spectrum of lichen planus, diabetes and hypertension associated with Greenspan syndrome, as described by Gupper, it is called as Greenspan syndrome, a classic triad. So if you have a patient with lichen planus, try to evaluate whether they are suffering from hypertension or diabetes in order to categorize them whether they belong to this Greenspan syndrome or not. It is a must criteria. So as you can see, look at this. Polygonal, right? Multiple ends. There is no definitive shape to this particular lesion. They appear to be slightly elevated. If you can appreciate, they are violaceous, purplish. See over here, edematous, surrounded by inflamed areas. Red areas are present. Okay, raised tissue areas like this, whitish appearing lesions. They will be tender. They will be that they can present pain and tenderness and those particular things. Especially if papules and all are present, they may burst open because skin is a highly frictional area, exposed part of the body. So they can give rise to open sores. Ulcers can be present, and this only complicates the clinical symptoms. It becomes more and more painful, and proneness to secondary infection also increases. A metallic taste or a blunt taste comes to the oral cavity. When lesions are present, patient will complain to you saying there may be burning sensation in the mouth. There is inability to taste anything. I feel that there is a metallic taste in the mouth. These should be the clues so that you can look for, because this is a non-specific symptom. Even OSMF tends to show you these kind of symptoms: burning sensation, loss of taste and all. So this will try to, for you to minimize the differentials that you're going to keep in mind. Once you observe and appreciate a pigmented area or reticular area or these bilateral striae, it's more than enough for your diagnosis. Dry mouth can be present, difficulty in swallowing. If the lesion has gone back into the throat or to the esophagus, definitely there is going to be restriction. See, again, a feature which is overlapping with that of the OSMF. Patient will complain that they are unable to eat hot and spicy food. Irritation can be brought about, elicited even with mild activities such as toothbrushing. Okay, so lesions usually appear purplish, flat topped, as I already mentioned. These lesions are not exclusive only for skin and the oral mucosa. Other mucosas also can be affected, such as the genitals, male and female genitals, urethra areas. Okay, all these areas also you can expect to see these lesions. Scalp. Skin lesions which appear on scalp, though it is rare, you don't get to see so much of skin lesions on the scalp. Psoriasis is much more common on the scalp, skin area. Lichen planus, not so much, but still, when you see it, it can result in temporary or permanent loss of hair. Okay. Nails. Nails, such as toenails and thumbnails and fingernails, again rare, but when it is present, you may not be able to appreciate violaceous patches, whitish patches over there, but you will see that there is thinning and ridging and splitting of the nails along with temporary loss of nail. So, see, on skin, what it appears can be seen in oral mucosa in this particular manner. That's why they said lacy, lace-like. Okay, nice striations, stria, thin lines of this white lacy area, along with intersections can be found, and these are known as Wickham striae. Okay, this is the characteristic fine white or gray lines or dots which are seen on the top of pruritic patches, papillary rashes of the lichen planus. Microscopic appearance. First of all, why does a lesion appear white? It is because of hypergranulosis, hyperkeratinization. So, and this is known as Wickham striae, named after the person Louis Frederick Wickham. So clinically, we can appreciate 6 different patterns of lichen planus. The first one is the reticular pattern, plaque pattern, papillar, bullous, atrophic form, ulcerative form, erosive form can be seen. The most classic presentation is the reticular pattern. So see over here. Reticular means something which intertwines, interlaps with each other. So look at this. Sorry. See over here. White, lacy lesions interacting with each other. This is the classic presentation of lichen planus, and most of the times you tend to appreciate this. It appears as characteristic lacy white lines, just like I described, which is known as Wickham striae, named after Louis Frederick Wickman. It is commonly the tissue is somewhat raised, and the patient may report that areas in contact with the tongue makes it feel like the tongue is feeling or coming across a rough area inside the oral cavity. So leading questions probably will help you to come to that. Now you had just seen the reticular areas. Now see, it's more or less a closed area, something like a leukoplakic patch, right? Whole area homogeneous white. So this is the plaque form. Okay, it is here the lichen planus lesions and plaque form presents themselves as thick plaques of varying sizes and shapes. The smooth surface appears to be smooth and it is somewhat lighter in color. Okay, as I said, the minute you look at it, it is leukoplakic lesion. Only thing is, it will not be not scrapable and all that. Take a history from the patient. Probably you will have your answer. The tongue in a particular area where these plaques may be noticed. The lesions, when they appear on the tongue, they result in the formation of bald tongue because of lack or removal of the papillae, atrophy of the papillae on the tongue. So they become bald in nature. Okay, the papillar pattern. The papillar pattern is noted. Look at this. Numerous papules, small patterns, right? So see over here, numerous pinpoint papules, small pinpoint, wide raised elevations, numerous, not more than 0.5 millimeter, not less than half a centimeter. when you see numerous of them scattered inside the oral mucosa. Papillary pattern it may be seen alone or it may be seen in conjunction pattern with the reticular pattern, the atrophic pattern, the papillary pattern. So you just have to give it a thorough look in order to assess that. This can be overlooked in an oral examination depending upon the number of papules and the distinct appearance of these particular lesions. Bullous form. Until now, I said that one of the P description in lichen planus was that it is planar, it's flat, plain topped. Now look at this. There is a nice bullous lesion that is present, a vesicle that is seen in this area. So this form consists of vesicles ranging from a few centimeters to diameters, and they are called vesicles. Because oral cavity is a highly frictional area, such a thin walled vesicle is prone to easily rupture, even with simple activities such as eating and drinking. So once it ruptures, what happens? It leaves behind an ulcer. Once you have an ulcer, symptoms such as burning sensation, inability to eat, and secondary infections, all these things set in. So those are all the secondary clinical symptoms that may get added up with the original existing one. Most common site is buccal mucosa or tongue area, both of which can turn out to be very symptomatic in these lesions. Next is the erythematous form of lichen planus. Look at this. Erythematous means red areas, red patches. You hardly see any whitishness over here. Look at the back. You need to scroll through the whole of the oral cavity. You cannot just look at this and come up with some erythroplakic lesion or erythroleukoplakia. No, please observe. There would be some Wickham striae, some representation which will point out a hint towards the lichen planus. So do a thorough clinical examination. So erythematous forms that are present. The atrophic form presents as diffuse reddened patches that may be in combination with other forms of lichen planus, such as white striations of the reticular form. These ones are usually most commonly seen on the gingiva, especially the attached gingiva, and patient may complain of high irritation and burning sensation, even bleeding as well, because brushing, eating, gargling, everything involves that's contact. Okay, lesions are poorly defined, and peripherally, you may have a suggestive feature of the striae that is going to be present. So, such red areas which are present on the attached gingiva sometimes gives rise to the diagnosis of desquamative gingivitis. One of the form of gingivitis is desquamative gingivitis, and lesions in this erythematous form qualify for that. Okay. Other skin diseases may appear similar, and this term is not a diagnostic one. Erythematous area is not a diagnosis, it's just a sign that you elicit, which can narrow down your line of diagnosis. In addition, the atrophic form may be confused with bullous mucous membrane pemphigoid and may appear similar to the gingiva that we just described. Atrophic form consists of red erythematous atrophic forms, sometimes described, may include reticular or plaque-like desquamative gingivitis. This form, when affects the surface, gingiva is definitely diagnosed through biopsy and immunofluorescence, because a whole lot of lesions can tend to appear erythematous. So we have to be very careful when we deal with these red appearing lesions. Red marginal area affected by lichen planus and we noted as plaque-like areas superior to the marginal areas. That would again be a diagnostic clue. The next one is the ulcerative form. Ulcerative form is the one that carries the highest risk of malignant transformation. When we talk about pre-malignant conditions, we do include lichen planus as one, OSMF is one, syphilis is one, this lichen planus is one. Again, not all forms of lichen planus will have a pre-malignant potential. It is the ulcerative form. So you need to be specific about that. The ulcerative form of lichen planus tends to carry a high rate of malignant predisposition. Okay, it is seen as one or several ulcers in association with any other disease forms. This form is quite painful for the patient And the soreness of the tissue will affect eating and brushing of the teeth. Obviously, very symptomatic. Ulceration may result or occur at any tissue site and may extend. It doesn't stay just in that area. If it has occurred in the buccal mucosa, it may proceed backwards, go back till it involves the tonsillar area. So that becomes more tough to swallow. Dysphagia and all will be present. Okay, so this form usually is thought to be associated with a high rate of malignant transformation, pre-malignant potential. Ulcerative nature of this form probably allows more detrimental tissue changes with chronic irritation and possibly a port of entry for pathogens. Erosive type. See, ulcerative when there is a complete separation of epithelium. When there is a break in the continuity of the epithelium, it is ulceration. But if this ulceration is limited only to the superficial cells, well, there is no actual break or discontinuation, only the superficial areas are affected, then it is known as erosion only. So, erosive type of lichen planus, it is a mixture of erosive and reticular lichen planus, which occurs on the buccal mucosa. Sometimes it may be associated with lot of Candida colonization, Candida albicans colonization, seen commonly on the tongue and the buccal mucosa. So, lichen planus lesions most of the time respond well to multi-component medicines, topical creams and lotions, which are a mixture of vitamin A, vitamin E, antifungal agent. Such things, when they are included, it tends to give a very good effect. Okay, highly erosive areas of lichen planus in the soft palate region. If you can observe, look at this lesion. You have a red area in the center, but scroll through the periphery, you will be able to appreciate a lot of white areas, white line that you can see. Because I'm talking about lichen planus, I have to mention a word on lichenoid reaction. Oid means like. So there are a lot of responses in the body that mimic lichen planus. Lichen planus, it is a T cell mediated autoimmune response. Lichenoid reaction, on the other hand, is a response which looks like autoimmunity. It's not exactly autoimmunity, but it looks like autoimmunity, usually brought about by a environmental agent, something very close, a topical agent, a new agent that you have used, like a bubble gum or a drug or a restorations, things like that. Whereas lichen planus is autoimmune, so treatment happens to be steroid. Whereas for lichenoid reactions, just go symptomatic, remove whatever is causing the agent, and that is sufficient. The lesion is going to regress. So see, it's two different completely different entity which may look very much alike. So it is very important for you not to miss the diagnosis. The most common material that we use in dentistry, which is capable of giving rise to this lichenoid drug reaction, is amalgam. The mercury in the amalgam restoration, there is continuous leaching of mercury, and that can elicit this particular response. Nowadays, most of the restorations have been replaced from amalgam to composite restorations. So probably that has become less, but other restorative materials such as acrylics and all tends to give a similar response. So dental materials do play an important role in lichenoid reaction. So look for immediately surrounding to that lesion, see if there is a new restorative material, if there is any kind of a prosthesis present in that area. Okay, mercury in the metal alloy usually causes hypersensitivity reaction. Hypersensitivity can also be seen to things such as flavoring agents in food products and drugs. Um, High cinnamon flavor, okay, cloves, all these things, especially in toothpaste, such as very strong toothpaste which with clove essence in them, tends to have this effect onto the oral mucosa. Lesions are usually isolated, and you know, try to remove the irritant that caused it, and the lesion is going to subside on its own. Histopathology. Okay, I'll go one by one. First of all, the problem is in the epithelium, because we know the antigen is the basal keratinocyte. So what happens is, there is going to be targeting of this basal keratinocytes, and there will be destruction of this keratinocyte. How did the keratinocytes die? Because of apoptosis, right? So individual cells group of cells may undergo this apoptosis, and thereby you will see that the epithelium, first of all, as a result of the insult that is occurring on top of it, there is a hyperplastic epithelium. This hyperplastic epithelium will either be parakeratinized or orthokeratinized. Can be can be any para or ortho. No issues as such. Because you see keratinization, that's why increased keratinization, that's why you see so much of striae formation, isn't it? So that is the justification to that. And if there is thickening, if there is hyperplasia of epithelium, which layer do you think the cells are going to be prominent? Spinous layer. So spinosum. Okay, lot of spinous cell hyperplasia is going to be see acanthosis is going to be seen in the epithelium. Okay, now going by each one, because of the loss of the basal cell individually or a group, the structural integrity of the retina ridge will be lost and there will be a collapse of the retina ridge. It's like those swings which have a wooden platter to sit on. If you remove the wooden, what happens to the rope? The rope comes and sags down like that. Your retina ridge collapses, and now instead of being short and irregular, the retina ridges are known as sawtooth retina ridge. Okay, this is a feature again which is can be commonly appreciated in see something like this. And skin, it is going to be very prominent. In oral mucosa, not so much, but you will definitely appreciate the change in the uh, epithelium. So what did we see until now? Hyperplastic epithelium, acanthosis. You see keratinization in the form of para or orthokeratosis. The retina ridges are sawtooth shape, isn't it? Okay. Now let's move on. Now appreciate this. The basal cells. See here, it is almost a flat interface. There is so much of atrophic epithelium over here. Na? So one retina ridge here. Okay. So now see, group of basal cells. Acha, here. See, I told you antigen cells, basal keratinocytes are identified as antigens and they are destroyed. So when they are destroyed, it is by apoptosis. So individual apoptotic cell or a group of apoptotic cells are known as cavate bodies. Cavate bodies, and this will be present limited only to the basal cells. Okay, see hypergranulosis is present just beneath the epithelium. Look at it in the connective tissue. What do you see? Lymphocytes. How are the lymphocytes? They are seen as dense band of lymphocytes. See over here, dense band. That should be the description of the lymphocyte. There should be a band of lymphocyte just beneath the epithelium. It shouldn't go deeper into the connective tissue. It should be limited there. Corresponding to that, you see lot of spillage of melanocytes because melanocytes are present in close association with basal cells. So when basal cells die, melanocytes also are disturbed. So they discharge their contents melanin and it spills out into the connective tissue. So melanin is a foreign body in the connective tissue. So a lot of macrophages come and engulf this spilled out melanin, giving rise to melanophages. This is the reason for pigmentation to be seen in the oral mucosa in chronic cases of lichen planus. Patient may say that this just started a week ago, just 15 days ago, but you know that it must have been there for years together because of the pigmentation that is there in the oral mucosa. Okay, chronicity, that should be one of the clue for you for identifying a lichen planus. Okay, so epithelium, hyperplastic, sawtooth ridges, cavate bodies, dense band of lymphocytes, melanophages, melanin in contingency. Okay, all these things comprise of this thing. Okay, one more thing is here. Sorry. See, there is separation of the epithelium from the underlying connective tissue, and this space or cleft is known as Max Joseph's cleft or space. Because of the weakening of the junction between the basal cells and the underlying connective tissue, there will be a split between the epithelium and connective tissue called as Max Joseph's cleft. Treatment, very simple. Now we know what is the etiology. The etiology is autoimmunity. So the best way we can treat it is by corticosteroids. Don't underestimate autoimmune disorders. They are very, very tricky, very symptomatic, very painful, very tough to control. Okay, so you will have to use corticosteroids. Usually, topical corticosteroids is the first line of choice, but if symptoms are very severe, itching and tendency to hurt yourself by itching and opening the sores, so secondary infections can set in. In those conditions, we may have to go ahead and give you systemic steroids. Okay, then inhibitors of inflammation can be used so that you can control the symptoms of lichen planus. Side effects may vary, prevent rejection depending upon the type of usage. Transplanted organs as a complication you get to see in them. Topical mouthwashes with ointments can be given. Oral pills are effective in treatment of lichen planus. In newer mode of treatment, such as injections of tacrolimus and pimecrolimus, can be used. They give the same effects of corticosteroids with lesser side effects, so that also can be considered as the drug of choice. If it is because of lichenoid drug reaction, then identify the drug that has been started and try to discontinue or replace the drug. It can give you better ones. As I mentioned, vitamin A, because it helps in epithelial maturation, that would be a good choice. Stress is known thought to be the main factor for the causation of lichen planus. So anything that can manage stress, such as yoga, natural therapy, gym, meditation, should be implemented in the patient's routine lifestyle. Thank you.